So here we are with another edition of the Osteopathic Lyceum podcast. This time we are building on the concept that I've put forth before, that osteopathy really doesn't have any theories. In a technical sense, it has hypotheses that are generally falsified already that continue to be utilized. We talked about the Fryat model and how the Fryat model really isn't what it says it is. So the Fryat model, we will, at least for the purposes of this, work with the concept that the Fryat model has been falsified. So what we're going to look at here is sacral models, or models of sacral mechanics. Now, what I will put forth to start is very simply that the obligate physical phenomenon of how the sacrum generally moves, or actually moves in a particular individual, is stable between individuals to the degree that it's similar enough with the notable individual variations. And that is to say that sacral movement is very, very minimal, very, very difficult to detect by a practitioner in an actual patient, and that there are varying explanations or varying models to explain this within osteopathy that don't necessarily agree with one another in their explanations, but they do agree on the basic observable phenomenon and how to essentially develop on a diagnosis where the interpretation is different, because it's just a different story. So if we start there, we start with the claim. The claim is that the sacrum doesn't move all that much, and that it is relatively predictable within a very small range of motion, how much it should move in varying individuals, and then you'll identify what it is doing within a particular individual that is different than expected or different than other people. But with respect to osteopathy, it is again that philosophical approach, that says ideas are the most real thing, so the ideas matter, and we just think stuff up and then we explain it. So the obligate physical phenomena is stable, the explanations are unstable. So what I would suggest is move away from the explanations, go towards the stable observation or the stable observable phenomenon, and you'll probably be in the place that you need to be, especially with respect to identifying what's going on with an individual patient and effectively helping that individual patient. So first, I'm going to go to Foundations of Osteopathic Medicine, which would be generally considered a standard text. So I'll bring that up here. For those of you who are listening, you won't see this. So again, I will do my best to appropriately portray what is here. So this is on page 590. This is the third edition of Foundations of Osteopathic Medicine. I believe there's a fourth, or I may be incorrect. This may be the fourth and there's a fifth. I'm not 100% sure, but we're in the section that has diagnosis of sacroiliac joint somatic dysfunction as the heading. It says the most common and standard diagnoses of SI somatic dysfunction include, but are not limited to, sacrum anterior, sacrum posterior, forward torsions, rotation of the sacrum on the same oblique axis, left rotation on left oblique axis, right rotation on right oblique axis, backward torsions or rotation of the sacrum on the opposite oblique axis, right rotation on left oblique axis, left rotation on right oblique axis. So that's all. Didn't finish. Bilateral sacral flexion, bilateral sacral extension, unilateral sacral flexion, which is a sacral shear, unilateral sacral extension, which is also a sacral shear. Those are your most common terms that are utilized according to Foundations of Osteopathic Medicine. Okay, we continue on with this, with the written here. In the osteopathic profession, several models of SI dysfunction have been described. 3 systems of nomenclature currently used to define sacropelvic mechanics are those described by the Strawn model, which is HPLA, the Mitchell model, which is muscle energy, and Van Buskirk/Still technique. The HPLA system is described in Walton's text, Osteopathic Diagnosis and Technique, Sacroiliac Diagnosis. Both the Chicago, now when they say Chicago, they mean Strawn, okay? Both the Chicago and Mitchell models describe similar events, but from differing points of reference. So you see what I'm saying here. So to pull out of the quote here, what I'm noting is that the phenomenon is the same, the descriptions are different, right? So they're noting here that the phenomenon, like they're looking at the same events, but they're thinking about it from different angles, so they're describing it from different reference points. Both systems, to return to the quote, Both systems are based on physiologic motion of the sacrum, pelvis, and lumbar spine. However, the Strawn model does not describe or identify what the Mitchell system refers to as backward sacral torsions, just as the Mitchell system has no equivalent for Strawn's posterior sacrum. The Still or Van Buskirk model looks at the sacrum in a unique way. It looks at sacral dysfunctions as more of a myofascial restriction that is present after the lumbar spine and pelvis has already been treated. The student of osteopathic medical profession needs to understand these three approaches in dealing with SI and pelvic somatic dysfunctions. Okay, so they're saying that there's three separate models. And if you're an osteopathic practitioner or osteopathic student, you really want to understand what the heck is going on with the sacrum, you have to understand three completely separate models to look at the exact same physical phenomenon. What I would say is that as far as education is concerned, as far as cognition is concerned, as far as cognitive load is concerned, that is confusing for no useful reason. What you're asking is for more details to be remembered, to be brought in to think about an obligate physical phenomenon that you have identified. That obligate physical phenomenon is a lack of motion where motion is expected. You're making people think far too much about something they don't need to think about. All they're trying to find is where it's not moving. It's a straightforward enough thing. Now, you need more details than that. You need to understand how the sacrum should move, knowing that it does not move much, and identify where it isn't moving in that individual. I don't need to think about how it's supposed to move in the Mitchell model, in the Van Buskirk model, and in the Chicago or Strawn model. I just don't need to think about that. This is a lot of thinking for nothing, but that is generated from a profession that centrally claims in this book that osteopathy is philosophical, or it is a philosophy more than anything else. In a separate book, it notes, and I believe it was a separate book, it may not necessarily be Foundations, essentially notes that philosophy uses a definition out of a specific dictionary, which I don't remember the name of, but says that philosophy is essentially thinking in more or less a formal way without evidence, right? So you can just think stuff up. Again, lots of thinking for nothing, in my estimation, based on evidence that I've accumulated over time. The Mitchell model of SI motion and dysfunction commonly taught in colleges of osteopathic medicine is that developed by Fred Mitchell Sr., DO, and amplified by his son Fred Mitchell Jr., and others. Mitchell introduced new vocabulary, new concepts regarding SI motion, and new diagnostic tests. The first publication of the article was the 1958 AAO yearbook entitled Structural Pelvic Function and republished in 1965. Lots of stuff there. Want to get to something here specific. So this ends up being on page 591. There's a very specific thing to point out with respect to the Mitchell model. And it says, in the Mitchell muscle energy model of diagnosis, two assumptions are made when determining an iliosacral diagnosis. The first is that the dysfunction is due to neuromuscular imbalance, with the muscles on one side being hypertonic and their opposites being hypotonic. The second is that the side of dysfunction is the side of the positive standing flexion test. So it starts off with two assumptions are made. Now, an assumption is something that you are thinking about whether or not the evidence is present. So according to the Mitchell model, when you find a sacral dysfunction, in whatever way you find it, you assume that the muscles on one side are high tone or hypertonic and the muscles on the other side are hypotonic. And you assume that the standing flexion test, or is it standing flexion test? Yeah, positive standing flexion test, that's where the dysfunction is. You just assume that, right? It's built in, which means that in the Mitchell model, you are assuming something and not necessarily testing it for its accuracy or for the accuracy of your assumption, which means that you could be making a complete and total error because you haven't checked something. So in obligate physical reality with a patient on the table who has a real dysfunction, not checking something is an error in all cases. It doesn't mean you've made an error in treatment because there are only so many parameters. Your error is in not checking. The next error could be generated from not checking, so you don't necessarily know what's going on. But you may avoid that error under the circumstances that your assumptions are accidentally correct, right? So there's assumptions built into the Mitchell model. This is not okay as a competent, responsible professional, right? So on that alone, you should throw out the Mitchell model in your practice as far as descriptions, because there's assumptions built into it which are not necessarily indicative of the real individual in front of you. Right. It goes on to more or less note that the Mitchell model is heavily related to L5, or it may not necessarily note it there, but essentially the Mitchell model, you're right on right, you're right on left, you're left on left, and your left on right are really references to what's happening at L5. So the second letter, right? So left on left, the second letter is the axis, which is determined by the side bending of L5. Your first letter is a rotation, which is opposite the rotation of L5, which is where you find the Fryette model built in as your assumption. So left on left means that L5 is side bending left and rotating right. Therefore, the sacrum is rotating left in relation or to compensate for L5, which is a Fryette type 1 mechanic. A right on left would be L5 side bending left, rotating left. So the second letter being the axis, which is side bending of L5, and then if you have a Fryette type 2, it is claimed to rotate to the same side, which means the sacrum has to rotate opposite to it to compensate. Now, this assumes that compensation is actually going to occur there, or that that's what compensation really means in the individual. Could mean many other things, but again, you're assuming. So it's built on the Fryette model, which we already know that we can throw out as invalid. It is a falsified hypothesis. It is not a theory. We can throw out the Mitchell model because it's based on faulty assumptions. One, the Fryette model, and also that you automatically have particular things happening with muscles without testing. Okay, the Chicago model, which is also the Strawn model, is the HVLA model. This comes from cadaver studies. Now, cadaver studies are not absolutely a problem when generalizing to living beings. However, they can be a problem. So you have to specifically look at how this was done. Being done in the 1930s, what I would say is that it is very unlikely that things were developed well enough to translate findings in a cadaver to findings in living specimen, because it would depend on how much dissection was done, how that dissection was done, the state of the cadaver itself. So there's lots of problems with that. And this one looks, I think, more... Any discussion, this is a quote, any discussion of the Chicago model must begin with an understanding that the sacrum is described in relation to the ilium. This seems a very logical approach when discussing the SIJ. There are two SIJs, one on either side. It is entirely logical when evaluating the relationship of the sacrum to the ilium that both sides can and should be explored for diagnostic findings. It always has depended on palpation for tissue texture changes, as well as looked at anatomic asymmetry. I'm going to skip ahead a little bit. In the Chicago model, the relationship between the sacrum and L5, the lumbosacral joint, is not defined. Assessment of L5 requires a separate assessment. L5 position is not part of the terminology of a Chicago SI lesion. Ordinarily, L5 rotates in the opposite direction of the sacrum. The term compensated L5 has been applied to this relationship. See Nelson, the sacrum, a bone of contention. Chicago model delineates two primary sacral dysfunctions, anterior and posterior sacrum. Both dysfunctions involve the oblique axis. Describe below are clinical findings of each. Okay, we don't necessarily need to go into that, but the Chicago model is looking at the sacrum in isolation of L5. The problem with that is L5 is there in the living specimen, and it should be understood to some degree. And this is why I tend to move back to the position of macro identifies micro. Large motions identify smaller problems because large motions are made up of smaller subcomponents, such that if the large motion doesn't work properly, the location of the smaller subcomponent is usually visible, especially if you have the patient positioned where the anatomy you're assessing is visible. Treat where it's not moving. Thinking about all of these in these faulty ways, thinking about the sacrum without noting L5 is a problem because L5 is there. L5 has much more notable motion than the sacrum does. Sacrum moves in relation to L5. L5 moves in relation to the sacrum to some degree, depending on how you want to talk about it. But to ignore L5 in your model is an absolute flaw, right? So now that we've looked at this, based on that faulty thinking, that faulty philosophical approach, you need to throw this out. You need to throw this out philosophically as well as scientifically. So the Chicago model, we now know, unfortunately, is moot. Right? The pelvic side shift, the Chicago philosophic approach. So I'm actually going to read this Chicago philosophic approach portion. The Chicago model is more than just two sacral dysfunctions and the pelvic side shift. The philosophical approach taught for generations stems from the teachings of Robert Kapler, D.O., FAAO. This pragmatic clinical approach cuts through the didactic biomechanical models and focuses on the patient. The approach starts with the clinician looking for an answer to the question, why is the sacrum in trouble? It also stretches stresses palpation for TTC, or tissue texture changes, as they signified altered physiology. Lastly, the philosophy stresses the concept of repeating the seated flexion test at the end of treatment to objectify the treatment response. In conclusion, anterior sacrums and posterior sacrums are definite clinical entities. Understanding these conditions and knowing how to diagnose them will provide a more specific and comprehensive understanding of SI problem and its causes. They described, so they used the term philosophy. They didn't do it properly here. Okay. They described acceptable diagnostic behavior. Test with, in this case, the seated flexion test. Apply treatment based on your finding. Retest with the seated flexion test. That is acceptable clinical behavior. Test, treat, retest with initial test. Don't retest with a different test, right? So that's just simple, good clinical behavior. But to say that that's philosophy is inappropriate. That's good, observable, stable clinical behavior. That's not philosophical. That's scientific. That's how you should be doing everything. So that's a really good thing to pull out of this, but not necessarily to describe it as a philosophical thing, right? It's, again, it's more thinking for no useful reason. It talks about styles. I'll read this really quickly. Dr. Edward G. Stiles has put forth the idea that in the normal physiological relationship between the ilia and the sacrum of each these three axes performs different function, personal communication to the writers of the textbook. According to his research, the superior pole corresponds to the axis of rotation for craniosacral motion and the cranial rhythmic impulse. Dr. Stiles proposes the middle poles have to do with sacral flexion and extension, e.g. lumbosacral flexion and extension. The middle pole is therefore the natural axis for iliosacral interaction. The inferior poles are proposed to be the axes for diagonal rotation of the sacrum in relation to the innominate and lumbar spine. So this is noting observation based on assumptions of an individual practitioner. So the practitioner is observing something up close to the head, observing something in the sacrum, relating the two because they happen in his observation at similar times in similar people, right? So this is an observational relationship. This is a pattern. The mechanism or the explanation he's giving is just a guess based on the observation. So to generate a hypothesis, first you need an observation. So he's got an observation. He's then providing you with an explanation that isn't necessarily formulated as a testable and falsifiable prediction. It could be. My guess is if you tested this and in a way that it could be falsified, you might find some relationship to the claim, you might find none. All right, so I'm not 100% sure what you would find. If in personal opinion, I have one, but that's not useful to the point here. But this could be tested, but you essentially what you have is the observation first of a pattern. You have an explanation, not necessarily stated in a way that would be useful because it's not formulated as it stands in a way that it is tested and falsifiable or testable and falsifiable. It's just you're relying on the claimed observations of an individual. So don't have to throw that out, but don't take that as having large credence in this form, in this written form. There may be stronger evidence in a different written form, but here you don't pick that up, right? Or you don't, it's not as useful. Contributions of Richard L. Van Buskirk, DO, FAAO, the still technique model. I'm going to read the quote here. Another important concept that is emerging, the emerging nature of SI disturbances which remain after treatment of the lumbar spine and pelvis is ligamentous and fascial and contrasted to a bony positional change of the sacrum and the ilium. AT still commented research and practice that after a technique is done and the restriction comes back, the problem is ligaments and fascia still. So the still model demonstrates that after treatment of lumbar and innominate sacral somatic dysfunctions, only two types of sacral dysfunctions seem to remain. Both of these sacral dysfunctions behave as if the sacrum was fixated at 2 of 4 restriction points, one superior, one inferior on each side. Okay, there's a bunch more here that isn't necessarily worth going into. What is worth commenting on is that you have another individual observing that you treat the lumbar spine and the pelvis, right? So you treat the things that you think you should treat to correct the sacrum, and it doesn't get corrected, at least in your diagnostic model. What then occurred is Van Buskirk read some Dr. Still and pulled out a concept that Still noted, possibly without appropriate experimentation to confirm or to disprove the assumption that it has to be ligaments and fascia. So Still was observing from the outside. Even if he was doing cadaver studies, he wasn't doing cadaver studies on the people he was treating in that moment. He made an assumption based on varying observations that it had to be ligaments and fascia. Van Buskirk took that assumption, implants it as a description of what's actually going on without knowing, right? So Van Buskirk, it has what you would consider a stable observable, or like a stable observation of a pattern, then applies a description he likes to explain it. That is inappropriate, so you can accept Van Buskirk's observation and pattern recognition, but the explanation should be thrown away. So again, stable observable patterns of sacral dysfunction or lack of motion in the lumbosacral or lumbopelvic sacral region, with explanations that are essentially moot on their face, right? So they can be thrown out without much more investigation. Now, most people would not agree with me on that, which is understandable. I completely accept that people won't agree with me on that. But based on both philosophy or acceptable philosophical thinking and acceptable scientific thinking, all of these are moot, right? They're just kind of useless on their face, such that if you were to investigate them scientifically, if you were to take these observed patterns, formulate a prediction that can be tested and falsified, and it does get tested and it does get falsified, and you then retreat to the position, well, science can't prove osteopathy, what you've done is shown why your explanations can be thrown out on their face. Okay, so we've got legitimate issues here. We've got legitimate problems with these things. We don't have a problem with identifying that the sacral does or does not move, or how much it is moving in a particular individual. We have a problem with the explanations. We have a problem with the thinking. I personally have run into a lot of people that really laud the concept of osteopathic thinking or osteopathic philosophy. Unfortunately, they don't seem to completely understand how philosophy functions, or how thinking functions, or how science functions, because they just seem to approach what they like and stay there, such that when evidence is provided that doesn't support the position, it supports the observation, it doesn't support the position or the explanation, they have a problem with it. I want you to understand very explicitly that stable observation, the stable phenomena, the stable patterns are observed. I have observed them. I agree that you have observed them, whoever you happen to be. What I don't agree with is the explanations, and I'm attempting to build a case as to why. Right now, what I'm going to do is take you over to information from a meta-analysis from 2020, which describes many studies, or the accumulated information from many studies about what the sacrum actually does. Right now, a meta-analysis is only as good as the studies it is able to include based on its question formulation and its inclusion and exclusion criteria. So not all meta-analyses are really good representations of all literature that's available. So that needs to be stated before I do anything else with this. So depending on exactly how this was constructed, or how the question was built and how the inclusion and exclusion criteria were built, there can be things missing, so they are not represented. Based on the biomechanical research that I've seen, based on the varying meta-analyses that I've seen, this is relatively consistent with what I've seen across time. So from essentially standalone research papers and from varying meta-analyses, this one is relatively well represented, or doing a good job representing what I have seen with consistency over time. Okay, the title of this is Biomechanics of the Sacroiliac Joint, Anatomy, Function, Biomechanics, Sexual Dimorphism, and Causes of Pain. This is from the abstract, so I'm giving you the quick hit version of this, and I want to look at the methods. So a thorough review of the literature is performed to analyze studies related to normal SIJ mechanics, as well as the effects of sex and pain on SI joint mechanics. Results: a total of 65 studies were selected related to the anatomy, biomechanical function, of the SIJ and structures surrounding the joints. These studies discuss the effects of various parameters, gender, and existence of common physiological disorders on the biomechanics of the SIJ. Right, and we'll look at the conclusions here just to kind of get through this relatively quickly. The SIJ lies between the sacrum and the ilium, connects the spine to the pelvic bones. The SIJ transfers large bending moments and compression loads to lower extremities. However, the joint does not have as much stability of its own against the shear loads, but resists shear due to the tight wedging of the sacrum between the hip bones on either side and the band of ligaments spanning the sacrum and hip bones. Due to these, sacrum does not exhibit much motion with respect to the ilium. The SIJ range of motion in flexion extension is about 3 degrees, followed by axial rotation about 1.5 degrees and lateral bending about 0.8 degrees. And then it just talks about the sacrum of the female being built differently, so wider, more even, less curved. So that's actually worth noting. So I'm going to go through this sentence just so that we note it. And then I'll go back to what was previously written. The sacrum of the female pelvis is wider, more uneven, less curved, and more backward tilted compared to the male sacrum. Moreover, women exhibit higher mobility stresses, lows, and pelvic ligament strains compared to male SIJs. Okay, so we're going to stop there for a moment. More uneven is a very important thing to note in a meta-analysis. So you essentially have data collected from a bunch of female pelvises and male pelvises in varying ways. So it's not going to be one way, it's going to be varying ways. And what they note is that female pelvises are more uneven. So they're noting more asymmetry in the structure of female pelvises as the common observation across a large amount of pelvises that have been studied. That is important. That notes that your expectation should be in the range that your findings in the pelvic region are going to be impacted as far as asymmetry by the fact that it is common for female pelvises to be more asymmetrical. So depending on the test that you're using to assess the female pelvis, you may actually not be identifying asymmetry of motion. You may be identifying asymmetry of structure. Again, that can't be stressed enough. You might think you have a positive test. You might just have uneven bones. Keep that in mind. We go back, please excuse me, to the general discussion of how much the SIJ moves. Flexion extension about 3 degrees. That is not much. If you pull up a protractor and look at 3 degrees as a practitioner directly on a structure, or even looking at a structure that doesn't move much, you are very, very unlikely to pick that up. That's an average. Some will move more, some will move less. Those that will move more, you might be more likely to pick up the motion. Those that move less, you will be less likely, but your average is 3 degrees in flexion extension. Axial rotation about 1.5 degrees. I have strong doubts that you're going to find that. Lateral bending about 0.8 degrees. You're probably not finding that. When you're testing a sacrum, your most common tests are going to be a bunch of iliac or ilium tests, your inferior lateral angles, your superior sacral sulcus, and then a sphinx test, right? So extension. Extension is really the thing that, oh, you seated flexion test. So flexion, standing and seated flexion tests, and extension, or the sphinx test. So your real motion findings are off of heavy flexion and heavy extension of the lumbar column. Because there's a lot of motion that your eyes are going to pick up, because there's a lot of structures. So to really get the lumbar column to flex, you flex everything. To really get the lumbar column to extend, you extend everything. So you're picking up a lot of motion that is ancillary or away from the actual sacrum, especially visually, because you're not canceling that out. It is in your periphery, if nothing else. There's a lot of motion that happens there. And it is dependent on the lumbar column actually moving. So realistically, the primary motion that you're testing is the lumbar column, and you are getting some belief that you have a related finding in the sacrum. Maybe you do, maybe you don't. But to not acknowledge that the vast majority of the motion is going to be impacted by what the heck is happening in the vertebral column generally, and the lumbar column specifically, is very unfortunately a problem. If you're saying it's definitely sacral motion, that's just because of where you're paying attention. You're completely ignoring all of the problems that would happen in the generation of the motion that would allow you to test the sacrum. So your standing flexion test and your seated flexion test, that's full vertebral flexion. Your sphinx test, that is full vertebral extension. If you're ignoring that and how that would impact your findings, unfortunately, you're missing a lot. So just be very careful with that. Also, bones are uneven normally. We now have a reason to believe that it's more likely that a female's pelvis is going to be more uneven across a lot of studies. So we know a lot of problems that are built into these models, and we know that the tests that are utilized are not isolating sacral motion. Now, the only test that I would say that is actually isolating sacral motion is sacral overpressure. So you actually squish the sacrum. Now, when you actually squish the sacrum, the patient's almost always going to be in prone. You're not necessarily acknowledging how much the patient is sinking through the foam on your table when you push on that side. You're not acknowledging how much the soft tissue of the patient is yielding on the anterior surface that you're pushing on. You're not necessarily acknowledging how much the hip may be extending as you push through that soft tissue, and that soft tissue yields, and then the hip extends. To not acknowledge that does not acknowledge the problem with sacral overpressure. Sacral overpressure is not a true test of sacral motion. The pelvis is not truly stabilized. It is relatively stabilized. And when you push, there's squish of your hand, there is movement of your wrist, if nothing else. There could be movement of your elbow, movement of your scapulothoracic joint. There's lots of problems here. The tests of the sacrum are not clear tests. They're noisy tests. Some of that noise is generated from full flexion of the vertebral column, full extension of the vertebral column, or the sacral overpressure, and many other things moving that you're not controlling appropriately. So the vast majority of the models to explain the sacrum have faulty tests, they have faulty assumptions, and they do all generate from a stable observational pattern. So the thing that I would keep is a stable observational pattern. You can find where stuff's not moving, especially if you use the full vertebral column to move, right? You've got a lot of stuff happening there, especially if you use overpressure. Now, I'm admitting that the overpressure test has a problem, but it is really good at identifying where something's simply not moving, because you'll have something move on one side that you push and not on the other. Once you identify where it's not moving, that's where you go. You don't need to think about it anymore. Find where things aren't moving. Use large motions to identify the smaller subcomponents. You already do that if you do a standing flexion test, a seated flexion test, and a sphinx test. You use large motion to generate all the subcomponent motions and identify where something's not moving. You're already doing it. Think about it differently. Think about it as this is a large movement, and wherever it's not moving, that's where I go. I don't have to go to the sacrum. I have to go where it's not moving. Any test that tests the full vertebral column should be seen as such. Don't just focus on where you put your hands. Step back and look at the whole thing. Wherever it's not moving, that's where you treat. To whatever degree that is the reason that something else isn't moving, it should start moving, right? So there's problems with the tests. There's problems with the interpretation because the interpretation is based on faulty assumptions. It is based on faulty thinking, faulty observation. So again, this unfortunately improves my confidence in my claim that osteopathy does not have theories. It has hypotheses that are both falsified already and consistently falsifiable. So when we think about osteopathic theory, we shouldn't be accepting that term with ease. We should say osteopathic hypotheses. We should note, as I've said many times, that the stable observable phenomenon and patterns are there. The manner in which they're interpreted, the manner in which the interpretation is attempted is the problem that I would claim that we have as a profession. You may well disagree with me, and I'm happy to accept that and happy to have the conversation about that. So hopefully some of that was useful, and we'll talk again soon.